Some people have asked if they can get CE credits for watching this presentation. It is the same presentation I've presented many times for various dental schools, CE programs, and some dental society programs, so I suspect you can. You should realize that this recording is being done the last day in May in 2016. Things do change, discoveries are made, and this presentation may not be valid next month if there's new research that comes out. The other thing you should understand is I am a general dentist. I have been going on 52 years, so my emphasis is on information needed by general dentists to do a better job uh, treating fearful people in their dental offices. This is being done under my corporation, seconddentalopinion.com. I'm Fred Quarnstrom. I hold some fellowships, Academy of General Dentistry, American Society of Dental Anesthesiology, International College of Dentists, and American College of Dentists, largely because I've been around a long time. And this is third in a series on nitrous oxide. I'll be talking about complications and contraindications to the use of nitrous oxide, the things you need to be aware of so you don't have any problems. Again, my name is Fred Quarnstrom. I live in Seattle, Washington. I'm also an instructor pilot, and if the truth were known, I'd probably rather be flying this afternoon. But nonetheless, I'm here and we'll talk about complications and contraindications. We'll also talk a bit about the Fink phenomena and the 5 C's of nitrous oxide. And I'll explain what those are when we get there. But basically, this will run a little over an hour and it'll give you everything you really need to know to use nitrous oxide. The good news is one study showed no complications for a series of 500 consecutive patients when the concentration of nitrous oxide was limited below 50% nitrous oxide. So that's very good news. In the 500 consecutive people, they saw no problems. But we'll talk about the problems I'm aware of in this presentation in case you should see any of them. The first one, and the one that probably gets the most notice, is nausea. Some people will become nauseated using nitrous oxide, particularly if you use high levels. You get up to 50%, 60% nitrous oxide. Be prepared because you may see somebody get nauseous. How often did this happen? Maybe once a year, maybe every other year. If it were going to happen, it would happen right before I was going to do a presentation to a large group. So I'd have to fess up, well, it was just last week. Kids seem to be the worst of the bunch. You need fairly high levels of nitrous with kids to get them relaxed. And if you're at that level, you may very well see nausea or even vomiting. A 47-pound child seems to be about 37 pounds of vomit. It's truly spectacular what their stomach content can be. Because of the potential for this, we always kept a large plastic wastebasket in the operatory where we put our contaminated papers, shelf covers, patient bibs, gloves, etc. I learned very early on to listen to my dental assistants because they're sitting up a little higher from the patient, they're sitting back a bit, they're passing instruments, and they will notice if somebody retches. You can't vomit if you haven't retched a couple of times. Your abdomen will suck in. You'll literally be able to see their backbone from the front side. When you see this happen, you've got maybe a couple of minutes. You may be able to talk them out of being nauseated or vomiting. But typically, we're concentrating on area millimeter, 2 millimeters in diameter in the back of the mouth. So we're not going to see that abdominal problem where they retch. So the assistant will, and if the assistant says to me, I think they're getting a little too high, I quickly take the mask off. I found over time if I take the mask off and tell them, we got you a little bit too high, take a couple of big deep breaths through your nose, blow it out, that's good, take another breath, blow it out, you'll be back to normal in a minute. In the meantime, the wastebasket's coming over under the head of the chair. If I've got a rubber dam in the mouth, I'm taking it out, and I'm sliding the patient's head to the side of the chair so that if they do vomit, it is caught in the wastebasket. Doesn't happen often, but it has happened occasionally. Uh, Once they're done and I've got their mouth cleaned out and they're coming back down, they're coming off the nitrous, I leave the assistant in the room to clean up the mess because I've got a hair trigger stomach. And if I stay, I may very well join the patient at the wastebasket. By then, the risk of them getting nauseated again is gone. Uh, and once an assistant has had to clean up a mess like that, they keep one eye on the tummy when they're passing instruments so that they will see the wretch and warn me that something's going on and I need to do something about it. And I'm smart enough to listen to them. If they tell me they think their patient's getting a little bit numb, I back off and get the mask off and start talking to them. The other thing that we would occasionally see are hallucinations. Uh, I walked into a room one day. I had a temporary hygienist that was working for us that day. Said good morning to the patient, and she broke down crying. She said, "This woman tried to kill me. I've never had so much pain in my whole life. It was awful. I just can't take this tooth cleaning." And so I talked her down and got her comfortable and suggested to the hygienist that in the state of Washington, she could use local anesthesia and she could use nitrous oxide. I didn't want anybody else that day to tell me that they'd had a lot of pain. So I went back to my patient, and I guess it must have been a half an hour later. I hear this scream, "Dr. Q, get to room one now." I walk in the room, and there's a woman sitting in the chair with her arms flailing in the air, screaming, "Ah, ah, 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 ah," on the top of her lungs. The hygienist is in the corner crying. She's had it. And what happened? Well, the lady hallucinated. I need to tell her who she is, where she is, and that she's going to be okay. I take the mask off. I say, "Sally," use their first name because they may not recognize their married name. You're in the dental office. You're fine. You got a little bit too high. You'll be back to normal in a minute. Take a big deep breath. That away. Blow it out. That's the way. Take another big deep breath. Blow it out. Sally, you're in the dental office. You're doing fine. You're safe. You'll be back to normal in a minute. Take another big deep breath. Blow it out. And within a minute, she's back to normal. The poor hygienist was a basket case. She'd never seen a nitrous hallucination again, so I sent her to lunch. So I now have her schedule and my schedule. We normally take lunch from 1 to 2. I finished both schedules about a quarter to 2. Someone had gone and got me a sandwich that was sitting on my desk. I sit back, put my feet up on the desk to enjoy the sandwich, and the receptionist comes in. "We need you out front. There's been an auto accident. Somebody's lying in the street." And I said, "No, get out of here. I don't want to know about auto accidents." "No, no," she says, "it's one of our patients." Okay, so I go out in the street, and here's a young man who is a patient of ours, and there's a motorcycle laying on its side there. Young man's leg is bent at a very strange angle. It's obviously broken. So I said, "Bob, how are you doing?" He opens his eyes. "Oh, hi, Dr. Q. I had a little accident." I said, "You certainly did. Just lie still. We've called the fire department. They'll be here to get you off to the hospital." Well, there was a tavern a couple doors down from our office, and here comes a guy out of the tavern who's 3 sheets to the wind, comes over and says, "Hey, Bob, give me your hand. Let's get you out of the street." I said, "No, let's leave him alone. I'm pretty sure he's got a broken leg. We don't want to move that. The firemen are coming. They'll know how to properly move it." The guy's got a cigarette hanging out of his mouth, and there's gas leaking out of the gas tank of the motorcycle. And he's about ready to punch me out. I've told him twice not to move Bob. And fortunately, that's when we heard the siren of the aid car that was on its way. Uh, the rest of the afternoon, I didn't need any more stress. I just walked in and said hello to patients. "It's so nice to see you. I'm going to take a quick look at your mouth here, and that's all we're going to do today." So you will occasionally see hallucinations. They're not particularly dangerous, but they're certainly frightening the first time they happen. Uh, Once in a while, you'll get an issue with hypnosis. I had a call from a friend of mine, and a good friend, and he said, "You know, Fred, I had this patient on 30% nitrous, and She went to sleep. I took the mask off, and I've tried to give her some coffee. I've spilled more coffee on her than in her. If I pinch her, she comes around and wakes up. But if I leave her alone, she stays back to sleep. And I said, well, yeah, just take the mask off. He said, I did an hour ago. Well, I said, she can't be asleep. And he said, you know that, and I know that, but trust me, she's asleep if I don't keep pinching her. I didn't know what it was. This was about 35 years ago. I called a good friend of mine uh, at the dental school in Oregon and asked him if he had any ideas, and he asked me the same questions I'd asked the fella. In fact, he called the fella and asked him the same questions because he knew something was squirrely. Well, we now all agreed she wasn't asleep, except she would stay asleep unless he pinched her. I did ask him, I said, what's her blood pressure? He said, well, she has a strong pulse. And I said, no, blood pressure. Remember, 130 over 70, 140 over 80. Well, she has a strong pulse. And I said, well, a strong pulse is better than no pulse, but we ought to have a blood pressure. And then he fessed up he didn't have a blood pressure cuff in his office. And again, this was about 35 years ago. So in those days, that wasn't uncommon. At any rate, he called her physician in the meantime and fessed up. And the physician said, well, just let her sleep it off. She'll take a little nap and be ready. Well, he'd had a pretty stressful morning. I think he needed to go home and change his shorts. And so the physician said, well, give her a quarter of a cc of your 1 to 1,000 epinephrine from your emergency kit. Inject it subcutaneously. That will stimulate her, and she will come around. And she did. After talking to her, we discovered that she was a pharmacist. And initially, I thought maybe this is some sort of LSD flashback, or I should say she was a pharmacy student. I didn't think pharmacy students would be messing around like that, but I probably was wrong. But she had been hypnotized before, and the effect of the nitrous reminded her of hypnosis, and she was basically in a state of auto-hypnosis. We've talked to some people that use hypnosis, and they suggested that this is a common problem that they see, and how they handle it is to count backwards to the person. 10 down to 1. 10, you're getting less and less relaxed, more and more alert. When I get to 1, you'll be completely back to normal, or you'll never be able to experience this wonderful sensation again. 9, you're getting less and less relaxed, more and more alert. When I get to 1, you'll be completely back to normal, or you'll never experience this sensation again. And by the time you get to 1, they're pretty well back to normal. Once in a while after nitrous, you won't have somebody who tends to be completely asleep, but they tend to be just very, very relaxed, even though you've had the nitrous off for 10, 15 minutes. Well, you don't want to put them in a car and let them drive home unless they're back to normal. And I've tried this backward counting with a couple of these people, and it seemed to make a difference. So it's something to remember just in case you get somebody who is slow and shaking the sensation of nitrous. Everybody knows nitrous oxide at the levels that we're using it, up to maybe 50% nitrous, is not a general anesthetic. Nitrous actually can be a good general anesthetic, but you need to be in a hyperbaric chamber at atmospheric pressure. It is not strong enough to put people to sleep. However, in my 52 years, I've had 2 people who were under general anesthesia, touched their eyelid reflex. There was no response. Gave them a little pinch, no response. So what did I do? Well, I took the nitrous mask off, and they returned to normal within a couple of minutes. They claim not to be on any other medication, but they certainly were under general anesthesia. They didn't respond to a pinch. They didn't have a lid reflex when I touched their eyelashes. So it sort of reminds me of the joke, a fellow standing on a street corner, dog's sitting alongside of him. His friend comes up and says, does your dog bite? And he says, no, my dog doesn't bite. So the guy reaches down to pet the dog, and the dog nails his hand. And he says, I thought you said your dog doesn't bite. The fellow said, my dog doesn't bite. That's not my dog. Well, nitrous oxide doesn't bite, but be aware that there are a few people who are hyper reactive. There are very few. I've only seen it twice. And if it looks like general anesthesia and they're not responding, get the mask off. And that's the takeaway from this presentation. Anything that goes wrong can be corrected by getting them back on room air. A few people, about 50% of the population, can have what appears like sexual phenomena. They appear to have a sexual orgasm on nitrous. Someone asked, well, what part of the population is that? And the answer is it's been reported, and I've seen it a couple of times. It is women who seem to have this ability or this issue. Consequently, if you're a guy, you have to be escorted at all times when you have a woman on nitrous oxide. Your assistant can never leave you in the dental operatory alone. And I test my staff when they first come to work for me. I'll suggest I need something, the left-handed screwdriver. And if they step outside the room, I tell them to get back here right now. Don't ever leave me alone. If you're left alone, and this should happen, as happened to a fella down in Oregon, it's your word against their word, and you're going to lose. So you always have to be escorted. I've been asked, well, how about women dentists, women hygienists? What if it's a guy? And so far, it's not been reported. So far, you're probably okay, but it's just a good idea to always have a second person in the room when you're using any sedation. Here's a letter that went out to a doctor in Oregon in the 1970s. After your appearance before the Oregon State Board of Dental Examiners, the board reviewed the testimony, your statement, and the complaint and additional statement filed by the patient that's been blocked out here. The board does not feel your actions in this case were appropriate. Certainly, your actions were not up to the standards generally expected of a dentist by your use of nitrous oxide on a patient without having a dental assistant present. The board believes this represents a serious error in judgment on your part. You are hereby strongly reprimanded for your conduct in the treatment of, again, the name of the patient's been blanked out. The board doesn't intend to take any further action at this time, but this reprimand now becomes a part of your permanent file. The guy probably didn't do anything. He was a nice guy. He got a call from the patient. She was in pain about 11 o'clock in the evening. He went to the office. Obviously, he didn't have a dental assistant there at that time. To get her out of pain, she was very fearful. He put her on nitrous, and she had one of these hallucinations and felt that he somehow had taken advantage of her. So you just have to be escorted. Once in a while, you'll get somebody that has an extended euphoria. You take the nitrous off, and we expect them to be back to normal within about 5 minutes, and they're just so happy and loosey-goosey. Think about the fact that it may be hypnosis, but whatever you do, keep them in the office until they're back to normal. Normal patients within about 15 minutes are more than safe to drive themselves home. Can't fly an airplane, the FAA wouldn't allow that. But these people that seem to have this extended euphoria, I keep them around for a while. Once in a great while, you'll have somebody cry. I was doing a course in Bellingham, a town north of Seattle here, almost on the Canadian border. There was a lady who at the time I considered elderly. She was probably in her 60s, no makeup, very straight hair, very plain dress. Took her a while to warm up to trying the nitrous. We like to have everybody in these courses give each other nitrous so they understand what the effect is and they get some practice in administering it. When they gave her the nitrous, she just broke down sobbing. I quickly went over, got the mask off, talked to her, got her calmed down. She told me the story. She'd worked for Dr. Jones for many, many years. Jones was not his name. And he had died about a month earlier. He was just the most wonderful dentist, the most caring person in the whole world. And he'd had the unmitigated gall to die before she was ready to retire. Well, we were close to the end of the day, so I finished the last lecture. Everybody went home. She was back the next day. I really didn't expect to see her. She had on a bright flowery dress. She had a new hairdo. She had makeup. She came in and gave me a big hug. And I said, I kind of worried about you last night. How'd you do? She said, well, you may have thought I cried here. The tears came in buckets at my home last night. She said, I really had not mourned Dr. Jones. Well, I did last night. I got it out of my system. This new fellow I'm working for, he's not much of a dentist, but he's going to get a lot better. And I kind of often have wondered how that relationship uh, went along. Now, would I use it with her if she were a patient of mine and she broke down crying one time? I wouldn't be opposed to it, but I'd certainly ask her permission before we gave it to her again, just in the off chance that she has this same reaction. Once in a while, you'll have somebody get the giggles, and it is known as laughing gas. They just giggle and giggle and giggle. Well, you can't treat them. They're moving around so much laughing. You've got a moving target, so you either have to shut the gas way down so they're getting a very low percentage, or just take the mask off. I had a fellow who came in. He was a fairly fearful fellow, and we used some nitrous. We were able to do his procedure. He seemed comfortable with it. He came back about 3 months later for his prophy. He said, "Don't ever use that gas on me again." And I said, "Really? What went on? Tell me the story." He said, "Well, I'm a recovering alcoholic. I had been dry for about 4 years, and I used that gas." And he said, "I just couldn't get to a bar fast enough after I left your office. It took me a few weeks to get back on the wagon. I've been dry again now a couple of months, but I don't want to take the risk of having that happen again." Well, fully understandable. We wouldn't want to break down his resolve and have him get back to drinking. We had at one time a drug treatment center who would occasionally bring kids to us that were having toothaches, and they were going through a drying out process with harder drugs. And we always had the directions: whatever you do, do not use nitrous with them or any sedative. Don't write a prescription for any pain medication. We will take care of their pain medication if they need it after they get back. So, recovering addicts, you probably want to avoid nitrous oxide with. The other group you want to avoid is people that have had recent ophthalmologic surgery, particularly if it's been a detached retina. Good friend of mine had a detached retina, and how they treat this now is they actually inject a gas into the orbit of the eye, and that pressure puts the detached retina back in place, and then they tack it down with a laser to scar it where it belongs, and it'll stay there. And they wear a wristband. This is a wristband he was wearing when I saw him the other day. It says no nitrous or no flying, and that wristband stays on until the gas is absorbed. The problem with a gas bubble in the eye is nitrous will diffuse into any gaseous spaces in the body, including this gas bubble, and it would increase the size of the bubble and increase the intraocular pressure, which is not something you'd want to do. There are two different gases that they use, and I'm not going to attempt to pronounce this first one. Its bubble will be gone within 8 weeks. It takes about 8 weeks for it to be resorbed. The sulfur hexafluoride gas they also use is gone within about 14 days. So that's a little bit less of a problem. But if they've had any sort of ophthalmologic surgery, they want to talk to their doctor about using nitrous. There are some side effects that are very rare. This top one, severe methyl enteral hexafolate, otherwise known reductase as MTHFR, is a condition that supposedly there are about 50 people in the world who have. It's big time with the naturopathic physicians. They find this and warn people about going to the dentist and using nitrous oxide. Even though it's almost unheard of, statistically, you will never see one of these people. There are a few anti-cancer drugs, bleomycin and deoxyribicin, that one causes pulmonary fibrosis, the other one can cause cardiac scarring. You'd be a little bit concerned. Some people, when they're on nitrous, perspire like mad, and after a half hour, 45-minute appointment, their shirt will be quite wet. I've never had one decide not to use nitrous the next time because they perspired. They really appreciate the fact that they can be relaxed. So I don't think it's a big deal if someone perspires. If they're uncomfortable about it, well, then they might not want to use it. Vasodilatation actually can be very advantageous if you're doing IV sedation because you can get those veins to really pop up. And you get a lot of pain control when you're using nitrous oxide, so the IV needle stick doesn't hurt as much. Tinnitus, noises in the ear. I've never had a patient complain about this. What does happen is they become more sensitive to background noises. They will hear people typing on the computer at the front desk. They will hear the ventilatory system in the office, where normally that sort of background noise we tune out. People on nitrous tend to notice that. For crying out loud, they hear everything you say. So don't come into the room and say, "Oh my gosh, Miss Bitchalot is here again today," because they will hear that and they will take it very personally. So the hearing doesn't really become more acute, but they do hear extraneous noises. Now, should they have a eustachian tube that's stopped up, they could have inner ear pain because nitrous would diffuse into the airspace in the ear. And the solution is take the mask off and it'll diffuse out. Lots of talk about people becoming bloated on nitrous. I haven't seen it in 52 years. Now, if they had a bowel obstruction, you wouldn't want to give them nitrous because it could diffuse into that space and increase the intra-bowel pressure, which you wouldn't want. And of course, every book you read, they talk about the flatulence from nitrous. And there was this woodcut showing the chemist here who's made up some nitrous, and the fellow's breathing it, and he's a little gaseous. This refers to a science demonstration that Morton saw, which caused him to think, or Wells rather saw, caused him to think this nitrous oxide might be a good thing to use in his dental office because in those days we didn't have local anesthesia. And if you had to do something, patient had a lot of pain. He watched this fella who took a dose of nitrous, tripped, stumbled, bashed his shin, ended up bleeding all over the place, and yet he experienced no pain. And that got nitrous being used in dental offices. In those days, you gave 100% nitrous till the patient turned a little blue, and you quickly snatched out the tooth and hoped that the pain of the extraction would restart their heart. It's a story that every medical student hears about dental offices, and so there's a lot of bias among some physicians about having their patients get nitrous oxide at the dentist. Well, of course, that's a long ways from how we use nitrous oxide now. So it's gotten a lot better over the years, but educate the physician if they tell patients that they shouldn't use it. There is a group that you should not use nitrous on, Treacher-Collins syndrome. It's a mandibular facial dysostoses. These kids, the lower half of their face just doesn't develop, and they tend to have a rather strange looking eyes. This fella here doesn't look that abnormal, but for the most part, you'll recognize these kids because they do look abnormal. It's about 1 in 70,000 births. The problem is they have very small airway passages. They have breathing problems. Their lower face is not well developed, so they can obstruct very easily. And nitrous oxide has led to at least one death due to obstruction of airways. Some of these kids end up having to live with a tracheotomy because of the restricted size of their airway. Dr. Tom's a dental anesthesiologist at UCLA, and he was quoted in this one case. Their airways are so tenuous and compromised because of their small jaws that even breathing normal is a huge problem for these kids. And it's very hard to rescue them if you have some sort of respiratory problem. Here's a picture of the young man, a 10-year-old, was given nitrous oxide by a dentist in fairly low doses from the review I did. And Tom said he'd only treat a Treacher Collins child in the hospital setting with a good amount of back rub, as getting into trouble with them anesthetically is highly probable. Their airways are so tenuous and compromised because of their small jaws that even breathing normally is a huge problem for these kids. And it's very, very hard to rescue a child from any sort of respiratory depression when they have Treacher Collins. So this is one patient you don't use it on. We're going to look at some masks of some new slides here. I talked about these in the last module, 102. Cannulas are something that I had used when if I were doing apicals on an upper anterior and the mask just got in my way. The problem with the cannula is it can provide you with about 8 liters of gas a minute. When your patient breathes, they breathe in about a half a liter of gas over a couple of seconds. And so the only gas they're getting through the cannula is this 8-liter total, which ends up being about a third of their breath. Now, for it to be effective, it has to be about 70% nitrous to get the effect that you would get of 30% with a mask, because they're bringing in a lot of room air. And then when they're exhaling here, all that gas is being blown out into the room. So you really have a problem with trace contaminants of nitrous. A couple of recent masks. Here's one that's nice and small, but it's got this small tube bringing gas into the mask and an equally small tube on the other side suctioning the gas away from the patient. You just can't move gas as fast as the patient is exhaling here through a tube that small. So you're going to have high concentrations of nitrous in the office. Here's one that's sold by one of the companies that does a lot of teaching. It's got 2 tubes here that go up the nares, essentially a cannula. They've got this hood and they've got suction on this hose here, but there's a bunch of holes here. So when the patient exhales, a lot of gas comes out of those holes. And in gases situations using masks like this or this, it's been shown the dental office could have levels of nitrous as high as 3,000 to 5,000 parts per million if you don't have effective scavenging. I'm not very happy with either of these, and the cannula is a device that will bail you out sometimes if you're working in an area where you can't use a mask, but you wouldn't want to use it on a regular basis. Here are some studies with this mask where they took a camera that was sensitive to temperature. And since exhaled air is at 98.6 degrees, normal body temperature, it's warmer than room air, and you can see the plume of gas that's coming away from this mask. So it's not doing a real good job of scavenging. This company showed a conventional mask here with this great cloud. The only way that could happen is if you didn't have the scavenging suction turned on, because a study here that was done by a friend of mine, David Donaldson, the brown mask, which is a mask within a mask, got levels below 50 parts per million in the operatory, as did the porter. In fact, almost all of the masks got close to 50 parts per million when they're being used to do dentistry. So I don't like these 2 new masks. This one is nice and small, but you can see here's the little tube on one side that brings gas to the mask, and the same size tube on the other side that you see here that has suction. It's just too small to get all that exhaust gas out of the area as fast as the patient exhales it. I do like this new mask. It's a mask within a mask. It's a clear shell now as opposed to the brown mask that we see here. And the inner mask pops in place, and it can be autoclaved, so it can be reused, or you can give them the patient and have them bring it back the next time. This mask, I'm sure, is going to be under 50 parts per million because it's just renovation of the brown mask that was very effective. Here is a new danger. I had never heard of this until about 2 months ago. There was a facial fire. The patient was on nitrous oxide via mask. They didn't mention how much nitrous. Her lips were very dry, so they moistened her lips with Vaseline. We've done that thousands, if not hundreds of thousands of times in my office. And the dentist was grinding on an implant fixture with probably a diamond burr, and he got a spark. The spark ignited the Vaseline on this lady's lips. Vaseline is petroleum based, and you now are using this mask so you have an atmosphere of nitrous oxide and oxygen there. The mask burst into flame. The patient's face and hair was severely burned. And so, to avoid this, never use Vaseline to moisten patients' lips. Use a water-based lubricant. There are lots of them around, and you don't have to worry about them bursting into fire. Here is this scavenging mask showing how much nitrous oxide would be in the area if you didn't have good scavenging. Picture on the left shows the lady's burned face, and the picture below her face is what was left of the nitrous oxide mask. So that's a new danger. The solution is don't use Vaseline to moisten patients' lips. Use a water-based lubricant. What are the contraindications other than the ones we've talked about? Well, anyone on any central nervous system sedation, if they're on Valium, Halcyon, any of the barbiturates, any sedative, you want to go very slow because the nitrous is going to be more effective. You titrate. You give a little bit, see how they do, get up to 25%. Are you feeling anything yet? If still nothing, go to 30. Go low, go slow. Use the least amount you need because with the sedation they have on board, it may turn out to be general anesthesia before you know it. COPD, or chronic obstructive pulmonary disease, is a no-no for two reasons, and we're going to get into this in some detail. They have blebs in their lungs that nitrous will tend to diffuse into, causing the bleb to become larger. And the amount of oxygen that you're giving them may knock out their desire to drive if they're on an oxygen drive. The nitrous also depresses their respiratory drive a bit. And so for various reasons, the COPD patient is not an appropriate nitrous patient. How will you know? Well, these are the sort of people that are pretty severe, and by the time they walk from your reception room into your treatment area, they will be huffing and puffing. So they're pretty obvious. They're pretty easy to diagnose. They're the emphysema patient, particularly long-term emphysema patient, or the chronic asthma patient can end up with COPD. Another contraindication, and this is relative, is a pregnant lady. A woman who's pregnant, I don't like to do dentistry on. I had a lady come into my office. She sat down. We had scheduled a bridge prep. I had a couple hours set aside for that afternoon. And she sat down and said, I'm spending my whole day in doctor's offices today. And I said, really? Tell me, what's going on? Well, she says, I'm about 2.5 months pregnant and I've been spotting. Whoops. I think we're not going to treat you today. I think you should get off to your obstetrician and let them evaluate your problem. So she agreed. I was able to catch up on my journal reading, and she had a miscarriage that evening. Had we treated her, we would always have known that we were the cause of her having her spontaneous abortion or miscarriage. It turns out that about 30% of pregnancies abort. Many times ladies don't even know they're pregnant. So it's not uncommon, but we don't want it to happen if we've just done dentistry. That day I decided I wasn't going to treat any more pregnant women unless they were infected or were in pain. They can go 9 months without getting their teeth cleaned. They really don't need that crown until they've had their baby. Now, obviously, if it's a front tooth that's broken off, I'm a caring person. We'll go ahead and fix that up for them. And if they need sedation, nitrous is by far the safest sedative you could give. much better than Valium or any of the benzodiazepines. They all have the ability to cause miscarriages, teratogenic effect. So if you've got to use sedation, nitrous would be the one. And you're only going to use it for half an hour, maybe 2 hours. Uh, and it's not been shown to be a problem in that situation. But let's look at chronic obstructive pulmonary disease. These people have a lack of surfactant. Surfactant is a chemical our lungs produce that tend to keep the alveoli at the same level they were. So little alveoli stay small, bigger alveoli remain a little bit bigger. Without surfactant, the small alveoli will tend to expand and there will be fewer and fewer of them, but the patient will have large alveoli. This means they have less surface area in their lungs to exchange gas. Because of this, CO2 levels tend to climb. When we breathe, we create carbon dioxide, and I've got some chemical symbols here. So here's our carbon dioxide that is produced when we metabolize food. Add that to water, you get carbonic acid. Carbonic acid dissociates into hydrogen ions and bicarbonate ions. And that is where we stimulate our breathing. The greater amount of hydrogen ion that you have in your bloodstream, the more your breathing is stimulated. With these chronic obstructive pulmonary patients, this level gets so high that their kidneys start retaining bicarbonate ions, and by doing so, this equation starts to shift to the left. So as they retain bicarbonate ions, that tends to buffer this, and the concentration of hydrogen ion goes down because the equation goes back to carbonic acid, and you might even get some separation of CO2. So the moral to the story here is the CO2 levels do not stimulate their breathing. If this gets severe enough, the secondary stimulus to breathing is low oxygen levels, and they may be on an oxygen drive, and that may be what is stimulating them to breathe. Well, about the time you give them a mixture of 30% nitrous oxide, 70% oxygen, they're going to have so much oxygen you can very well knock out their oxygen drive. A story I heard happened in a VA hospital. A fella came in first part of July, which is a very dangerous time to go to the hospital, because come the 1st of July, the medical students become interns, the interns become residents, and none of them yet are smart enough to realize they should pay attention to the nurses, because the nurses will keep them out of trouble. At any rate, this fella comes in. He's very cyanotic. His lips are blue. His nail beds are blue. And this new intern says, he's not breathing enough. Let's put him on some oxygen. So they put him on some oxygen, and he was a COPD patient. That knocked out his breathing drive, and he stopped breathing. So then they had to put him on a respirator, and it's my understanding it took him a few days to wean him off the respirator. So there's two reasons. One is the high levels of oxygen that could block their oxygen drive, and the nitrous tends to make their oxygen drive less sensitive. We'll see that here in a minute. So a normal set of lungs, you've got a negative pressure in your pleural space. All the alveoli are nice small alveoli. When the patient inhales, this negative pressure brings air in. I should be in this diagram here. When they exhale, they still have a negative pressure, but the air is able to get out. With the diseased lung, they have these large blebs. They have lots of mucus in their breathing tubes. They've got scarring. So when they try to exhale, they have a positive pressure in their pleural space, which may shut off some of these small bronchiole that you should get the air out with. The mucus plugs may plug some, and some of these alveoli have scar tissue around them. So they're just not exchanging gas very well. Here's more of a histologic view of the lung, and you can see the small alveoli. And here's the emphysematic lung. You see the scarring here. You see the positive pleural pressure shutting off these airways. With a bleb this big, this would probably be a surgical case. They'd want to go in and remove that lobe of the lung, because if that ruptures into the pleural space, they're going to have a pneumothorax and they're not going to be able to breathe with that lung. So this may be a bit of an exaggeration, but this is what you're looking at. A normal, healthy alveoli, here's the bronchioles here. You see the small alveoli. We got a capillary here with red blood cells. So the bronchial passageways bring oxygen to the alveoli. It diffuses into the capillaries where it takes up residence on the red blood cells. The CO2 is exhausted out of the blood into the alveoli, and when the patient exhales, they blow that carbon dioxide out. And that's basically how we control our breathing rate, is the amount of carbon dioxide. Here is our emphysematic lung, where we see the alveoli have broken down. They're very large. We see black particles here, which is probably smoke particles. So it was probably a smoker. The larger particles would have been brought up via the mucociliary escalator, but in the severe smoker, that escalator doesn't work, and so they get phagocytized by white blood cells and end up in lymph nodes. We've talked a bit about this. Food plus oxygen creates carbon dioxide and water. And here you see the oxygen diffusing into the alveoli, and here you see the carbon dioxide leaving the alveoli to be breathed out. One of the functions of the lungs, of course, is gas exchange. You bring in oxygen, you breathe out carbon dioxide. The other major function of the lung is acid-base regulation. As you build CO2, it combines with water to carbonic acid. Carbonic acid dissociates into hydrogen ions and bicarbonate ions, and it's the hydrogen ions that stimulate you to take a deep breath. When I was in physiology in dental school, we had a study where we breathed 2% CO2, 3%. I was a guy that breathed 10% CO2. I emptied a whole garbage can sized vessel with the respirometer in about 55 seconds. I've never breathed so hard or so fast in my life. The CO2 is a wonderful respiratory stimulant, unless you're a COPDer and you have blunted the effect of the hydrogen ions by resorbing bicarbonate ions. You basically buffered the system. So in the breathing tubes, we have these very microscopic fibers that beat and bring up particles that have gone down into your lungs. If they're greater than 2 micron, this will bring it up. And in the morning, you blow your nose and see how many little marmots crawled into your nose last night. In the smoker, they've lost those little cilia, so they don't bring this garbage up. They end up with much more of this garbage in their lungs, and their alveoli get broken down and look like so. So how do we breathe? Well, we have stimulus here that sends a signal down to our diaphragm, and when the diaphragm contracts, it makes the chest cavity bigger, and so we draw air into our lungs. As our lungs stretch, there are stretch receptors that send an inhibitory signal up to the inspiratory area saying, stop, don't inhale anymore, and it shuts this signal off so that our diaphragm relaxes and we exhale. And we have voluntary control over breathing, as I'm doing now when I talk. I can take a deep breath, I can blow it out, and so we have voluntary control. We've beat this equation to death, but the hydrogen ion is a primary stimulus of the respiratory center of our midbrain that then stimulates the inspiratory area, causing us to take a breath. When the stretch receptors get stretched, they say stop, don't stretch any bigger, or you're going to break the alveoli, and so this inhibitory signal shuts that off, and we exhale. There are aortic bodies that are involved in this also. They're located at the bifurcation of the subclavian and common carotid arteries and the bifurcation of the internal and external carotid arteries. They're sensitive to low levels of oxygen, below 60 torr. That's pretty low. We visit Bolivia every so often, where my wife grew up, and you get off the airplane at 13,500 feet. You're down about 40% of atmospheric pressure, and you really notice that you're out of breath, but the level of oxygen isn't to the 60 torr, so you really don't hyperventilate. However, your nitrous oxide will depress this stimulus, so that's why we want to avoid it on the COPD patient. So here's our carotid body that's sensitive to low oxygen levels. Here's our aortic body. Both of these send stimulus to the respiratory center to breathe, and that is also stimulated by the hydrogen ions. We also have irritant receptors there, which is what causes us to sneeze when we get a whiff of pepper. So there's many things going on there that cause us to breathe. And if we give the patient a lot of oxygen, you'll knock out this reflex. You'll lose that stimulus. And if you get nitrous oxide in this area, that too will depress that respiration. Let's take a look at what happens with CO2. Here we see the respiratory, the minute volume in liters per minute. And you see as the CO2 levels rise, we are stimulated to breathe much faster, up to 10%. Above 10%, CO2 is a respiratory depressant and was one of the first general anesthetics discovered. They put some cats to sleep with CO2. So it's a very potent respiratory depressant because it disassociates into hydrogen ions. The pH of the blood is buffered, and it changes very dramatically in these lower concentrations of CO2, and it's that pH change that stimulates our breathing. If we look at the stimulus from low oxygen, you really don't see much stimulus to breathe more until you're getting down here about 6% oxygen, where in room air we have about 21%. So the chronic obstructive pulmonary patient has a pretty lousy set of lungs if he's getting the equivalent of 6% oxygen. The other thing we have to be careful about is narcotics. Here you see the normal response to CO2 levels at 38 millimeters of mercury. You're going to breathe about 2 liters per minute. At 42, you're up around 4. In this range is somewhat normal, about 5 liters per minute. Give them a narcotic, say Demerol, like meperidine, and this very much depresses their stimulus to breathing. So they will bring in much less air at even higher levels of CO2. There's some anatomical considerations. Asthma is caused by the elastic fibers contracting. There's also some muscle fibers around the bronchi, and if they contract, it makes it very hard for the asthma patient to exhale. This occurs down here in the bronchioles, where we have the fibers but no cartilage. In the trachea and bronchi, we have cartilaginous rings that help keep the breathing passages open. But without that, these passages tend to collapse. And of course, the alveolar size in the COPD patient, they have much less surface area to breathe with. Two main types of COPD patients. The pink puffers tend to be little skinny folks, but they've got a lousy set of lungs. They probably were long-time smokers. And I had a banker that was in a bank not far from my office, came in for a denture. He only had a couple of lower teeth that were badly broken down, and he had a partial. I said, you know, we ought to do endo on those roots and save them. That'll hold on to the bone level in your mouth, and your dentures will have better retention as you get older. And he said, "Come on, who are we kidding, Doc? You read my medical history. I'm a severe COPD patient. I don't have all that many years left. There's no reason for me to worry about the level of that bone in 10 years. I'm not going to be here that long." And in fact, when we took his teeth out, his blood was not very red. It was more brownish. And looking at him, his blue nail beds and his blue lips indicated that he really wasn't carrying as much oxygen as you might like. And of course, I didn't use nitrous oxide with him. The blue bloaters are not only do they have a bad set of lungs, they're COPD patients, but they're also in congestive heart failure. These are the folks that their ankles are hanging over their shoes. They have blue lips, blue fingers. They purse their lips when they breathe because by pursing their lips, they create a little more positive pressure in their breathing spaces, and so they're able to breathe better. Under no circumstances should you give these folks nitrous oxide. Now, the question is always asked, well, I see people at the mall all the time with their little oxygen tank and the nasal cannula. That's true, but they're getting very, very low levels of oxygen, but it does make them more functional. But we don't want to be giving them the 50-60% nitrous that we could give with the nitrous mask. We probably beat this to death, but again, this is the area which is sensitive to low oxygen levels, and it's an area that is depressed by the effect of nitrous oxide, just cementing the fact that we don't want to give these folks nitrous oxide or, for that matter, supplemental oxygen. So there are some maybe contraindications. Nasal obstruction, well, if their nose is all stopped up, they probably can't use a nasal mask. A boxer who's had his airways in his nose crushed isn't going to do well. Some people are claustrophobic. They can't tolerate a mask on their face. And I've had some success starting them with a cannula, get him relaxed, and then go to the mask. And they seem to appreciate it and they're relaxed, so they breathe okay. People with upper respiratory disease, if they've got a cold or the flu, they shouldn't be in the dental office. You don't want to catch it, and you're going to have a hard time sterilizing all the tubes and masks that you're using. Tuberculosis, most of these people won't be coming in for dentistry. They got problems enough, but you wouldn't want to put them on nitrous if you did see them. HIV/AIDS patients, they usually won't tell us, so we know we use it on them. There's some issue that most anesthetics do depress the immune system a bit, and you wouldn't want to do it, but these people do well on nitrous. Pernicious anemia, I doubt if that's going to be a problem. You're giving them high levels of oxygen, which is probably helpful. These come out of ultra-conservative books. We're going to talk about the Fink phenomenon. Probably every one of you, certainly I learned in dental school that you should put people on 100% oxygen after you give them nitrous oxide because of diffusion hypoxia or the Fink phenomena. Ray Fink was an anesthesiologist at the University of Washington, and he noticed when people came out of surgery, they, in the recovery room, would look pretty cyanotic, bluish lips, blue nail beds, and suggested they should all be given supplemental oxygen. And it worked. Their color came back, and it became a known fact that whenever you have an anesthetic, you should be given some supplemental oxygen in the recovery room. Well, the difference is the MDs were doing surgery on these folks, and it had some heavy-handed surgeon rummaging around in their abdomen or in their chest. Plus, they'd had some very potent respiratory depressing drugs as a general anesthetic, and they weren't breathing as deeply as they should, and it hurt to take a deep breath. And so Dr. Fink was right. These people needed supplemental oxygen. I was doing a course down in Salt Lake City, and the first thing we did early the first afternoon is let everybody try nitrous. 6 liters of oxygen, 2 liters of nitrous. until you just begin to feel a little bit of euphoria, and then put them on 100% oxygen because I didn't want any diffusion hypoxia. So I'm at this course, and one of the fellows comes up and says, "Hey, we've got a lady back here that's asleep." Well, I move pretty fast when I'm nervous. I go back, I grab her arm, and I get a pulse. So her heart's beating. That's good. So my pulse rate dropped from 200 down to about 160. I give her a little pinch to stimulate her. No response at all. I touch her eyelashes. No response at all. She's under general anesthesia. I'm looking at the machine, 80% oxygen, 20% nitrous oxide. Uh, she shouldn't be feeling anything, or very little, if anything, and yet she's out under general anesthesia. So I shut the nitrous off as I'd learned and turned the oxygen up. So we give her more oxygen. A minute goes by, 2 minutes goes by. She's still not awake. I'm getting pretty nervous. And when I get frightened, my IQ drops like a brick. I really don't know what's going on, but I'd sure like her to be awake. And I probably need to go change my shorts. I had a stroke of genius. Out of nowhere, I decided, let's get her back on room air. She was fine on room air. Let's get her back on room air. So I took the mask off, and literally within about 30 seconds, she was awake. And I said, "How are you doing?" "Oh," she said, "I had a little nap." I said, "You certainly did." So we declared a coffee break. I needed a cup of coffee. And I come back and I'm looking at this machine, and I'm seeing a blue hose go down to a green tank and a green hose go down to a blue tank. I had set these machines up that morning, and I had set this machine up backwards. How could that possibly happen? Well, if you looked at the previous module, you already know the answer. There are some pins in the yoke that this tank top fits up into, and those pins are in different positions for oxygen and nitrous. Unfortunately for me, this machine had the pins poked out the back of the yoke, and I was depending on those pins to keep me from setting the machine up backwards. I'd put the nitrous on the oxygen side and the oxygen on the nitrous side, and I just scared the poo out of myself. Fortunately, I had taken the mask off, which was against everything I had learned in school and everything that you will learn if you read a book on the use of nitrous oxide. All authors say you should oxygenate. The pins that you see here were missing, and I'd managed to set it up backwards. Since then, I had an instance where this washer, let's go back and take a look at it, had stuck to the yoke, and I put the next washer on the tank. So I've got two washers here, which pushes the yoke far enough from the pins. I managed to set that machine up backwards also. So I thought, well, what if we took the mask off? I wonder if we really see diffusion hypoxia. So I got a pulse oximeter and a recording device, and I did a little study. We had 43 men, 61 women. You can see their average age was about 36 with a range of 18 to 68. Here's their weight, their height, uh, sedation in minutes. I probably should have removed this patient. They were only on it for 3 minutes. I don't know what we were doing, but it didn't take long. And what we're doing with the pulse oximeter is we're measuring what the saturation is of their hemoglobin molecules. And we always want it to be above 90% at sea level. And you'll see here in a minute that the altitude in Bolivia, we aren't that high. Got a little Down syndrome boy. He's actually in his 30s. And he came in one day, cyanotic nails, cyanotic lips. I called his physician and said, he's not looking very good. I'm wondering if I should send him to the hospital. He said, no, don't do that. He's got some major problems with his major vessels, and he's always a little cyanotic, and he really doesn't like the hospital. But I wouldn't work on him. Well, hey, I'd already figured that out. So he's back a couple of weeks later. He was running about 50% hemoglobin saturation. And so he's back a couple of weeks later, and he's looking much better. He's this happy self. And I said, I want to put your finger in that thing again and see what it reads. Well, the best we could do was about 70%, which had to do with the transposition of some major arteries. So in our case, we always want it to be above 90%. Now, when you've got somebody on nitrous, you're giving them so much oxygen, they're usually at 100%. So what does the pulse oximeter do? It shines two different frequencies of light through your finger. It's got some sensors here that senses the purple light, which is absorbed by your deoxygenated red blood cells, and the other sensor senses the red light, which is absorbed by the oxygenated red blood cells, and it goes and through the magic of integrated circuitry, it tells us what percentage of hemoglobin is saturated with oxygen. Remember, we want it to be above 90. So here's the little clip that fits on your finger. Here's my pulse oximeter, and I managed to rent this chip recorder that uh, plugged into our pulse oximeter, and we could watch their oxygen saturation. So we have this strip that comes off. Here we start the nitrous oxide, and I wrote what percentage the patient used, and their saturations went to 100% because with 40% nitrous, they got 60% oxygen. Room air is only 21% oxygen. They've got 3 times the amount of oxygen they have in room air. And then we marked here when we took the mask off, we didn't oxygenate, and then we watched the saturation for the next 5 minutes. In this case, this is where we took the probe off the finger. And this was our findings. This is percentage of hemoglobin saturation. Down below here, this is when they came into the office. The lowest person we saw had a saturation of 93. A number were 100% saturated. This is one standard deviation. The average saturation of the person walking into the dental office was 97%, with this standard deviation from 98.5 to 95.5. Then we put them on nitrous oxide, and the average saturation went to 99%. A lot of people were at 100%. The lowest we saw was 96. When the dental procedure was done, we took the mask off and let them breathe room air. And we watched the saturation drop. It ended up about 0.5% lower than what it started here. And if you just sit still in a chair, your saturation will drop because you're not exercising to move the air. But the point is, everybody stayed above the 90% line here. So what this little study did, and we showed it with lots of help from the statisticians at the dental school, was it showed that diffusion hypoxia does not exist in dental offices where you're using nitrous oxide as a sedative, which is good to know. So you can take the mask off without worrying about diffusion hypoxia. We think it's a good idea to leave the mask on with 100% oxygen because you've got scavenging going on and you're getting the exhaled gas out of the operatory. But if anyone ever goes to sleep for you on 100% oxygen, take the mask off because you may have switched lines. I managed to do it. I know of about 70 offices where plumbers switched lines here in the Pacific Northwest. There was a near death in Texas in an oral surgery office. A young man went in to get 4 wisdom teeth out. The lines were switched. The oral surgeon put him on 100% oxygen, watched the saturation fall from 100 to 95 to 90 to 85 to 80 to 70 to 75. He thinks he's looking at an allergic reaction. It goes to 60, it goes to 50. They finally called the paramedics when it got to 40. It was 35 when the paramedics arrived. They put him on their small tank of oxygen, and it bounced right back up to 98%. But here we had a star athlete, an A student who woke up with severe vision problems, a seizure disorder, and a marginal IQ because lines were crossed. So if in doubt, take the mask off. We could actually teach you everything you need to use nitrous oxide in about 20 minutes. However, the American Dental Association and most states require you have a 14-hour course, and most states require some recurrent training uh, every 4 or 5, maybe 6 years. And by the time we finish this lecture today, I will have put almost 4 hours of CE on YouTube, and you probably need to have 5 in some states, 7 in other states, and I'll be adding some more modules in the future. So the 5 C's of nitrous, what you have to do to stay safe. Number 1, keep the patient conscious. If they're conscious, everything is fine. They're unconscious, take the mask off. C number 2, keep them comfortable. That's why you're doing it. You don't want someone vomiting for you. You don't want them feeling like they're whooping through space on the blades of a helicopter because they're uncomfortable. Keep them comfortable. If they're getting too buzzy, take the mask off. Let them get to normal. Avoid the 2 C's here, COPD, chronic obstructive pulmonary disease, and the Treacher-Collins syndrome patients. Those 2 groups of patients shouldn't get nitrous oxide. Always keep the concentration of nitrous above 30%. Oxygen. In fact, I would suggest you probably should never go below 50% oxygen, because you're going to see your complications if you're above 50%. I had a guy that came in, he didn't want to have local anesthesia. We had a pretty simple little DO bicuspid, and I thought, well, we probably can do this with nitrous. So I put him on 40% nitrous, started the prep, and he started having pain. So I went to 50%, gave him a little longer. It was better, but he was still hurting. So I got to 65% and was able to finish the prep when he tore the mask off, stood up out of the chair, and took a swing at me. He was hallucinating. It happened at about 65% nitrous oxide. So you don't want that sort of excitement. I didn't want to get too far away from him, because if he fell and broke his teeth off, guess who was going to be restoring him? Freebie. It took him a minute or two. He shook his head and he says, "Oh my God, did I hurt anybody?" And I said, "No, but how about sharing with us what just went on?" Well, he says, "I thought I was in a bar and you'd insulted me, and no one insults me and gets by with it," which is why he'd taken the swing. So don't go there. Don't use more than 50% nitrous. In fact, 99% of the time, you'll do fine with 40% or less. And the 5th C, keep the gas flow, the minute volume, adequate to remove the patient's carbon dioxide, meaning you got to be giving them, rough rule of thumb, at least 5 liters per minute of fresh gas. The other C's of nitrous is be able to figure the concentration of nitrous. And it's kind of fun. We've tested people at a couple of courses, and we found that a lot of people forgot what they learned in high school on how to figure percentages. The way you do it, if you're given 3 nitrous and 4 oxygen, you add the 2 flows together, so you get 7 total, and divide into what you want to know. So you're giving 3 nitrous. If you want to know what percentage of nitrous, you divide 7 into 3. You're going to have to get your calculator out. It's 42% nitrous. If you're given 1 nitrous and 3 oxygen, that's a little easier. 4 divided into 1 is 25% nitrous oxide. If you're given 6 nitrous and 4 oxygen, be careful. You may very well see somebody hallucinate because you're at 60% nitrous, but you're still giving them 40% oxygen, which is more than they're getting in room air. If you're given 6 nitrous and 3 oxygen, it's time to back up. You're up to 67% nitrous. I don't think you want to go there. And heaven forbid, if you're given 5 nitrous and 1 oxygen, you're now at 83%. They're not getting as much oxygen as they get in room air. They're hypoxic. You don't want to be there. So for that reason, I put an X through that calculation. A couple of comments about nitrous oxide. It's 1 oxygen molecule, 2 nitrous molecules. Molecular weight is about 1.5 times that of room air. And initially, when we started using this, we figured, great, the stuff they breathe out will settle to the floor because it's denser than room air. The problem is it's been heated to body temperature, so in fact it rises and it tends to mix throughout the operatory. It's colorless. It's supposed to be a slightly sweet taste. I'm not so sure about that. I've not noticed it. If you compress it to about 50 atmospheres, it becomes a liquid in the tank. It supports combustion just the same as oxygen. If you blow nitrous oxide on a lit match, it'll burn much brighter. If you blow oxygen on a lit match, it'll burn much brighter. In the US, it's made by taking ammonium nitrate and heating it. You get nitrous oxide, oxygen, you get some water, and you get a lot of energy. So you got to be sure that you're cooling it if you're producing it, because there have been some explosions. There are some impurities to the production of nitrous: nitric oxide, nitrous dioxide, ammonium, carbon monoxide, and chlorine. I wonder, where do you get the chlorine out of ammonium nitrate? It turns out it's from the burlap bags that the ammonium nitrate comes in. And we did mention it depresses the aortic body's response to low O2 levels. We've talked enough about the pulse oximeter, other than to say we always want our saturation to be above 90%. We did a little trip to Bolivia, and the oxygen level in the air in Seattle at sea level is about 160 torr. You get to 10,000 feet, it's about 110. You get to 13,000, it's under 100. We went to a picnic at 16,000. It's down about 95 torr. And I brought my little finger pulse oximeter to see how we were doing. Well, at sea level, the 8 of us that went, our saturation was about 97. Here's a box plot. In the airplane that was pressurized to about 5,000 feet, our average was about 95. At 10,000 feet at our friend's home in Bolivia, the average was at 90. One of us was down here at about 83. At 13,000 feet at the El Alto airport in La Paz, the average was down here about 86. And again, one of us was down here in the high 70s. When we went to 16,000 feet for the picnic, my wife, who was on a beta blocker, so her heart didn't speed up, was down at about 75% saturation. Our average was about 79. So with altitude, you're going to have to do some calculations, but the extra oxygen will help. And so is a pulse oximeter necessary when you're using just nitrous oxide for sedation? The answer is no, because it's going to read 100% all the time because of the high levels of oxygen. And they come with these little finger ones, which is sort of the end of my talk today. This was a Bolivian dentist. He had his briefcase on a little stand, and he had a bunch of dentures here that were processed. And if you wanted a denture, he would use a quick set acrylic, take an impression in your mouth while you were standing there in the street, and he played with it until he could see it had reached its initial set, and then he had a knife in here that he would trim the extra extension off with, and you left with a denture, and it cost you $30. You think we work hard in the US? This guy works hard. So, can you get CE credit for the program? Some states will allow you to claim credits for online CE, but check with your board to be sure. To prove that you paid attention while you were watching this presentation, I have prepared a 10-question quiz. If you don't know an answer, watch the program a second time so you're sure to pass. And to get the test and a completion certificate, send $30 to seconddentalopinion.com at this address, 5767 South Oaklawn Place, Seattle, Washington, 98118. I will send you the test. You then complete the test and send it back. Again, you can watch the program again to be sure you pass. I'll grade the test and return the test with a certificate of completion, which should work for your board.